Right, National EMS Education standard competencies for this chapter. Shock and resuscitation. Applies fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for a patient in shock, respiratory failure, or arrest, or cardiac failure or arrest, and for post-resuscitation management. The pathophysiology will apply comprehensive knowledge of pathophysiology of the respiration and perfusion to patient assessment and management. One sec. Introduction. Shock is a state of collapse and failure of the cardiovascular system, also known as hypoperfusion or low perfusion. The body attempts to maintain homeostasis in the early stages of shock. So the body will attempt to maintain a state of balance in the early stages. If the shock is not reversed, then the compensation mechanisms will fail. Blood circulation slows and eventually ceases, and this can lead to death. Shock can occur because of a medical or traumatic events. Heart attack. This could include heart attack, severe allergic reaction, automobile crash, gunshot wound. AEMTs must be constantly alert to the signs and symptoms of shock. Physiology of perfusion. Perfusion is the circulation of blood within an organ or tissue in adequate amounts. And within the circulation, the exchange of nutrients and oxygen must occur, and the removal of waste and carbon dioxide must occur so that the cells can carry out what we would consider to be normal metabolic function. The body is perfused via the circulatory system, and the circulatory system consists of the systemic circulation and the pulmonary circulation. So the systemic circulation, that's the circulation of blood within the body, and the pulmonary circulation is the circulation of blood within the lungs. Cardiac output. The volume of blood the heart can pump per minute. That's what is referred to as cardiac output. And cardiac output is influenced by myocardial contractility, preload, and afterload pressure. Preload pressure is the pressure that builds up within the ventricles before they contract. That's what is referred to as preload. That pressure that causes the ventricles to stretch before they contract. Afterload is the pressure that the blood moves against in the vessels after it leaves the ventricles. So the pressure inside of the arteries that the blood must flow against, that is what is referred to as afterload. Cardiac output equals the heart rate times stroke volume. Stroke volume is the amount of blood ejected with each contraction. Blood pressure equals the cardiac output times systemic vascular resistance. So blood pressure is the amount of blood pump per minute times the resistance. So the blood being pumped and the flow against resistance is what is going to give us a blood pressure. Now, you as an AEMT or above, you must be familiar with pulse pressure and mean arterial pressure. The pulse pressure is the difference between the systolic and diastolic pressure, and it represents the force of contraction, how forceful the contractions of the heart are. Normal range is 40 to 60 millimeters of mercury. Anything below 40, you should start to think about weak contractions, which can reduce cardiac output. So you're thinking about shock. If it's over 60, then the contractions might be too strong, and that can put a patient at risk for stroke. So that's the pulse pressure. The mean arterial pressure is the average pressure required to circulate blood to the organs within the body within a cardiac cycle. So the average pressure that is necessary to circulate blood within the body to the vital organs is the mean arterial pressure. So the mean arterial pressure gives a clearer picture of how perfused the brain and the core organs are. And there's a formula for you to work that out. A normal mean arterial pressure should fall between 70 to 100 millimeters of mercury. Anything below 65 should be concerning. It means there is poor perfusion at that point. The formula that I use is 2 times the diastolic, so 2 times the diastolic plus the systolic pressure divided by 3. That's the formula that I use to work out mean arterial pressure. So that's 2 times the diastolic pressure plus the systolic, and then you divide that number by 3. As you go forward in your training, I will expect you to give me a pulse pressure and a mean arterial pressure with your vital signs. So that should be second nature when doing your vitals. I want a pulse pressure, a mean arterial pressure, and you should know what it represents and what it means. Now, Physiology of Perfusion. The autonomic nervous system controls the cardiovascular system. It is regulated from the upper part of the medulla oblongata of the brain. The sympathetic nervous system prepares the body for physical activity during a stressful situation. The parasympathetic nervous system is responsible for rest and regeneration. You should be familiar with the actions of the sympathetic and the parasympathetic. So you need to know what the sympathetic does to the pupils, what it does to the arteries, what it does to the lungs, what it does to the GI tract, what it does to the heart. And the pictures that are depicted, so the picture on the left is sympathetic response, and the one on the right is parasympathetic. So the sympathetic response will cause the pupils to dilate. It causes the arteries to constrict. It causes the lungs, specifically bronchial muscles, to relax, and it slows down activity in the GI tract. So if a patient is in shock and the sympathetic kicks in and they have food in the stomach, that food is not going to be processed. So the patient is going to be at risk for vomiting. The sympathetic increase the functions of the heart. It increase heart rate, it increase force of contraction, it increase the conduction speed. On the right, the parasympathetic, basically the opposite of the sympathetic system, it will cause, so the parasympathetic cause the pupils to constrict. It doesn't affect arteries. It doesn't affect the lungs. It will cause the GI tract to increase salivation and increase motility. So it increases the activity of the intestine. That's the system that plays a role in digestion of food. And with the heart, it will decrease the heart rate, decrease contractility, and decrease the speed of conduction. All of those things will slow down the function of the heart. Very important slide, learn it. Now, regulation of blood flow, sphincters, capillary sphincters. They regulate blood flow through the capillary beds, and they are controlled by the autonomic nervous system, specifically the sympathetic. Determined by cellular need, accomplished by vessel constriction or dilation. So depending on the type of activity that is occurring within the body, the autonomic nervous system will stimulate the capillary sphincters to constrict or dilate to increase blood flow to specific areas or reduce blood flow to specific areas. This will allow the maintenance of blood flow, perfusion. So maintenance of blood flow or perfusion is accomplished by heart, blood vessels, and the blood working together. So all these components must work together to get for the body to have proper perfusion. Respiration and oxygenation. So even though the circulatory system is working effectively, if there's not adequate respiration and oxygenation, then the perfusion process will be incomplete inside of the body. So respiration and oxygenation. The alveoli receive oxygen-rich air with every breath. Oxygenated blood passes through the alveolar wall into the pulmonary capillaries. Diffusion, molecules move from an area with a higher concentration of molecules to an area of lower concentration. Carbonic acid breaks down in the lungs and carbon dioxide is exhaled. Now let's look at the pathophysiology. So shock can result from inadequate cardiac output. It can be something is wrong with the heart and the output is significantly reduced. It can occur from decreased systemic vascular resistance, and what that means is the blood vessels are too dilated. So if the blood vessels are too dilated, the systemic vascular resistance is decreased. That means there is less pressure moving the blood inside the blood vessels. It can be due to inability of RBCs to deliver oxygen to tissues. The body attempts to compensate by shunting blood from more tolerant organs to vital organs. That's how the body compensates for shock. It's going to redirect blood flow from areas that do not or can go without blood flow longer and direct the blood flow to the vital organs, brain, lungs, heart, kidneys. Now, the perfusion triangle consists of the heart, which is the pump, blood vessels, which is the container, and blood, which is the content. These components make up what we call the perfusion triangle. Once these components are functioning effectively, the process of perfusion will occur as long as oxygen can reach the blood. When a patient goes into shock, it will affect either area of a specific area of the perfusion triangle or multiple areas. Now let's look at the components. Blood. The vehicle for carrying oxygen and nutrients. It contains RBCs, white blood cells, platelets, and plasma. Blood clots. Blood clots control blood loss, form depending on retention of blood and changes in the vessel walls and the blood's ability to clot. So the process of blood clotting involves vasoconstriction, specific blood cells, and certain types of proteins. It can become unstable and it is susceptible to rupture. The body's neural or hormonal mechanisms are triggered when the body senses a falling blood pressure. And the first place in the body that low blood pressure is detected is the kidney. So that's the first place that the body is going to realize that the pressure is not sufficient in that area. When this occurs, the sympathetic nervous system assumes more control of the body's function during a state of shock. The parasympathetic nervous system controls involuntary functions. Compensation for decreased perfusion. We have baroreceptors, and baroreceptors are protein sites that will detect low blood pressure and flow within the body. Chemoreceptors are chemical protein sites that will measure shifts in the amount of carbon dioxide in the blood. Specifically, it's going to start to pick up changes in the pH. Stimulation occurs when the systolic pressure is between 60 and 80 millimeters of mercury. Hypoperfusion. Once hypoperfusion is detected or low perfusion is detected, this will activate the renin-angiotensin aldosterone system or RAS system, as it is sometimes referred to. So basically, renin, which is a protein enzyme or hormone that is produced by the kidneys in the juxtaglomerular apparatus. The renin, when produced, so when the blood pressure is too low, renin is produced and by the kidneys, and renin will convert angiotensinogen, which is a protein produced by the liver, to angiotensin 1. So we have one liver, angiotensin 1 is in the liver. That conversion is going to take place. Then angiotensin 1 is converted by angiotensin converting enzymes in the lungs to angiotensin 2. So angiotensin 1 is the liver. Angiotensin 2, that conversion is going to occur within the lungs. And these are enzymes, protein enzymes. Now, when angiotensin 2 is formed, this is going to trigger the body to release aldosterone, which is a hormone, and antidiuretic hormone. When these two hormones are produced, the end result is it's going to cause the body to retain more sodium. So it's going to cause sodium retention. And if sodium is being retained, water is going to be retained. And that is what the body needs to keep the blood pressure at a level that the core organs can still be perfused. So that's how the renin-angiotensin aldosterone system works. The initial compensatory mechanism increases preload. It increases stroke volume and pulse rate. Autotransfusion effect allows the body to compensate for volume loss of up to 25%. So autotransfusion simply means that there will be shifting of fluid in areas where there is a drop in fluid. If hypoperfusion persists, myocardial function will worsen or worsens, and this decreases cardiac output and the ejection fraction. Tissue perfusion is going to decrease. There's going to be leaky blood vessels. Perfusion to the brain and the coronary arteries will be compromised, and the cells will switch to anaerobic metabolism, which does not produce enough energy and can produce lactic acid, which can lead to metabolic acidosis. The production of epinephrine and norepinephrine will occur at this point. Epinephrine will directly affect the heart and the lungs. That's beta-1 receptors in the heart, one heart, two lungs, beta-2 receptors in the lungs. Norepinephrine will more affect alpha receptors in the blood vessels. Norepinephrine comes out first and causes the blood vessels to constrict, and then epinephrine comes out to sustain the effects. Pecking order. Plan shunting of blood from areas of lesser need to areas of greater need. So that's the body's compensating mechanism. It's going to start to redirect blood flow from areas that can go without it longer than the core organs. Failure of compensatory mechanism to preserve perfusion results in decreases in preload and cardiac output. So the filling pressure in the ventricles is going to drop, and if enough blood is not entering the ventricles, then enough blood cannot leave the ventricles to go to the core organs and the rest of the body. Shock is well developed at this point. Shock-related events at the capillary and microcirculatory levels. So there will be cellular ischemia, and this occurs with decreased perfusion. There will be anaerobic metabolism, which results in systemic acidosis and depletion of the body's normally high energy reserves. The incomplete glucose breakdown will result in an accumulation of pyruvic acid. So you have pyruvic acid when the glucose doesn't break down properly, and you can have lactic acid. Once it's an acid, it's going to cause the pH to become more acidic, leading to a metabolic form of acidosis. Continuing with the capillary and microcirculatory issues. There is cellular flooding, and this causes explosion at the lysosomal membrane and the release of lysosomal enzymes, which are cell organelles. These are structures found within the cell that are important to degrading and recycling cellular waste. Their lysosomes are also important to energy metabolism. So they play a part in the degrading and recycling of, of cellular waste. They play a role in cell signaling and the energy metabolism. Continuing buildup of lactic acid and carbon dioxide acts as a potent vasodilator. So the more the carbon dioxide and the lactic acid builds up, the more dilated the blood vessels will become. White blood cells and blood clotting systems are impaired, and this leads to disseminated intravascular coagulation. So clotting factors start to get used up and the blood is unable to clot. Found to complicate septic shock. So this is an issue that can cause serious problems for a patient in septic shock. Then this will ultimately lead to multiple organ dysfunction syndrome. So progressive condition characterized by combined failure of several organs. It occurs when injury or infection results in the release of numerous inflammatory mediators and the activation of the complement system. The complement system is important to the process of inflammation, coagulation. So when it's activated, there will be inflammation, coagulation, pain, cell proliferation, vasodilation, and it will affect the blood pressure. When the coagulation system is activated, this is going to cause cells and proteins to form clots, which will help to deal with blood loss and they play a role in the healing process of wounds. When the kallikrein-kinin system is activated, this will trigger inflammatory reactions as well. Actually, let me reverse that. The kallikrein-kinin system is a system that is responsible for inflammation. It's going to cause inflammation. It's going to cause coagulation. It's going to cause pain. And it is going to play a role in cell proliferation, vasodilation, and it will affect the blood pressure. So that's the kallikrein-kinin system. The complement system is complement proteins that will specifically trigger inflammatory processes that help to fight infection in the body. All right, now signs and symptoms of multiple organ dysfunction syndrome: hypertension, insufficient tissue perfusion, uncontrollable bleeding, multisystem organ failure caused by hypoxia, tissue acidosis, severe local alterations of metabolism. Respiratory insufficiency. Insufficient concentration of oxygen in the blood can produce shock. So if there's an issue with the respiratory system, it can lead to shock. And worst case would be respiratory acidosis. Poisoning may affect ability of cells to metabolize or carry oxygen, and poisoning that it would include poisoning like carbon monoxide or cyanide poisoning, which interferes with how oxygen binds to the red blood cells. Anemia or abnormally low number of RBCs can result from chronic or acute bleeding and results in hypoxic tissues. Now, causes of shock: bleeding, respiratory failure, acute allergic reaction. So it can be pump failure, low fluid volume, poor vessel functions. Expect shock if a patient has multiple severe fractures, abdominal or chest injury, spinal injury, severe infection, major heart attack, anaphylaxis. Types of shock. Shock may be the result of a variety of causes. Hypovolemic shock is shock due to inadequate blood volume. It can be hemorrhagic and non-hemorrhagic in nature. hemorrhagic as a result of excessive blood loss, non-hemorrhagic, the plasma is lost from excessive vomiting, excessive diarrhea, or severe burn. The non-hemorrhagic shock occurs when fluid loss is contained within the body. And usually that fluid loss will create what we call third spacing. And I've already explained to you what third spacing is. It's when fluid end up in areas in the body where it cannot participate in normal metabolic functions. Abnormal losses of fluids and electrolytes will lead to dehydration, and it may occur through gastrointestinal losses, that's vomiting and diarrhea, increase and excessive sweating, internal losses from peritonitis, pancreatitis, ileus, plasma losses from burns, drains, and granulating wounds. Other causes include ascites, that's excessive fluid accumulating in the abdominal area, diabetes insipidus, which is an issue with anti-diuretic hormone, and osmotic diuresis. Remember that the osmotic pressure is the pulling pressure, second to hyperosmolar states. Earliest signs of shock are restlessness and anxiety. Patient may be thirsty. Patient may be pale, cold, clammy. Pale, cold, and present with clammy skin. The heart speeds up. As bleeding or fluid loss continues, the blood pressure will drop. Now, cardiogenic shock. This is caused by inadequate function of the heart or pump failure. So there is a direct problem with the heart. It develops when the heart cannot maintain sufficient output. As afterload increases, the cardiac output will decrease. For obstructive shock, this is indirect issues with the heart. It results when conditions that cause mechanical obstruction of the cardiac muscle also affects the pump function. It can be a cardiac tamponade, which occurs when blood leaks into the pericardium. It can be a tension pneumothorax caused by damage to a lung tissue where air starts to accumulate in the pleural space and collapse that lung and cause it to shift or cause the lining to expand in the mediastinum where the heart and major blood vessels are found, indirectly affecting the heart's ability to push blood out. It can be as a result of a pulmonary embolism, which is a blood clot that occurs in the pulmonary circulation. So this is a clot that forms within the venous system and ends up travels to the right side of the heart and end up in the pulmonary artery, causing a blockage and preventing an insufficient amount of blood going to the lungs and returning from the lungs to the left side of the heart. So the cardiac output is compromised. Distributive shock results when there is widespread dilation of small arterioles or venules. Septic shock is a result of severe infections. Bacterial toxins will damage the vessel walls. So if it's distributive shock, it means that the blood vessels are too dilated for whatever reason, whether it's a bacteria causing the problem, whether it's the patient just fainted, whether it's a spinal injury, right? Something is causing the blood vessels to dilate too much. So the end result is widespread vasodilation, but the cause is specific, whether it's bacteria, allergic reaction, spinal injury, or fainting. Neurogenic shock due to damage to nervous system that controls size and muscular tone of blood vessels. All vessels below level of spinal injury dilate widely, increasing size and capacity of vascular system. Blood vessels are too dilated, the pressure inside the blood vessels will fall. Anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized. It results in widespread vascular dilation, there is increased permeability, and the patient is going to have bronchoconstriction. So with anaphylactic shock, they can't breathe properly, and the blood is not circulating properly either because the blood vessels are too dilated and too permeable. Psychogenic shock occurs when patients have a sudden reaction of the nervous system that produces temporary generalized vascular dilation, resulting in fainting or syncope. Now, the progression of shock. Shock occurs in two successive stages. First stage we're going to look at is the compensating stage. Early stage of shock. So the compensating stage is the early stage of shock while the body can still compensate for blood loss. Chemical mediators are released by the autonomic nervous system. The pulse pressure, which is the systolic pressure minus the pulse pressure, should be within normal range. Can be a little below, but it shouldn't be less than 30. If it's less than 30 for your pulse pressure, shock is well developed. In the decompensating stage, this is a late stage of shock when the blood pressure starts to fall. The blood volume decreases to more than 30%, and the compensatory mechanisms start to fail at this stage. In irreversible shock, this is shock that has progressed to a terminal stage. Arterial blood pressure is abnormally low, and life-threatening reduction in cardiac output, blood pressure, and tissue perfusion will occur at this stage. We don't want them in irreversible stage because there's not much we can do for that patient. So we need to catch them in the compensating phase and decompensating stage. These are stages where interventions might be able to assist the patient. Now, patient assessment. Scene size up, look for and address hazards and threats to safety of crew, bystanders, and patient. More traumatic injuries make it less likely that the patient will be able to compensate. Once we have completed the scene size up, the next phase is your primary survey or primary assessment. Perform a rapid full body scan of the patient, identify and manage life-threatening concerns, quickly assess the patient's breathing, assess the patient's circulatory status. If the patient shows signs of hypoperfusion, then you want to establish IV access early and treat aggressively and provide rapid transport. And if you're establishing IV access for shock, you're thinking about fluid resuscitation. So you want the largest IV catheter that can fit. And in some patients, you might want to establish 2 IV access. After the primary survey or primary assessment, the next phase is going to be history taking. Determine the chief complaint, obtain medical history, be alert for injury-specific signs and symptoms, quickly obtain a sample history. Blood thinners can make bleeding injuries worse. Excuse me. After your history taking, then you have your secondary assessment. This is where you're going to repeat your primary. You're going to look at your intervention, see what have worked, make adjustments if you need to, downgrade or upgrade. Start with a full body exam, obtain a complete set of baseline vital signs, use your monitoring devices. Entitled CO2, pulse oximetry, put your patient on your cardiac monitor. You may need to obtain a 12-lead ECG if you think it's necessary. Reassessment, assess, intervene, reassess. Determine any effects of interventions performed and interventions needed. Focus on supporting the cardiovascular system. Patients in decompensated shock will need rapid interventions. And that's your patient assessment. Now, with a patient assessment, not complicated. All you need to ensure is that before you make contact with your patient, you categorize the patient. So that's the most important thing. Before you make any type of contact with that patient, categorize the patient. If you categorize the patient, you'll know exactly the type of approach you need. So when you approach the patient, is this a patient that is talking to me? If he is, that's patient category 1, right? When you approach a patient, if he's not talking to you or he's semi-responsive, does he have visible chest rise? So if the patient is semi-responsive with visible chest rise, that is patient category 2. If the patient is unresponsive but visible chest rise is still present, that's patient category 3. And as I've stated many times, once a patient has visible chest rise, that defines respiratory distress. So my management in terms of oxygen therapy, I am thinking supplemental high or low flow devices unless the patient is showing signs of severe respiratory distress. If the patient is semi-responsive with poor chest rise, that's category 4. If the patient is unresponsive with poor or no chest rise, and if no chest rise is present, they have a pulse, that's category 5. If the patient is unresponsive with no chest rise, no pulse, that's category 6. From 4 to 6, these are patients in which I must consider the use of airway adjuncts. These are patients in which I must be thinking about breathing for the patient. Once you're able to establish the category that the patient falls in, your management, your assessment and management will be smooth. Emergency medical care for shock. Treatment begins during the assessment process. Control all obvious external bleeding, excuse me. Place the patient in the position dictated by local protocol for shock patients. Provide warmth, gain IV access, and administer fluid. And the fluid of choice is going to be isotonic crystalloid solution. So the options are normal saline lactated ringers or the lactated ringers. If you're going to give 5% dextrose in water, it means you're considering to give a medication. So really the fluid of choice is normal saline lactated ringers. Golden hour. This is the first 60 minutes after the injury, sometimes referred to as the golden period. Provide initial management for shock. So manage the airway, administer supplemental oxygen, place the patient in a position of comfort, obtain vital signs, establish IV or IO access for medication or fluid boluses. Maintain body heat. And if you're going to be establishing IV access, then just marry it with cardiac monitoring. So if you're thinking about establishing IV access, think about putting your patient on a cardiac monitor, think about the need for a 12-lead ECG. So these things go together. Once you start to think advanced, think about all the advanced. Does this patient need an advanced airway? Does the patient need IV access? If the patient need IV access or IO access, I need to put this patient on a cardiac monitor. So these are things that need to become second nature. Once you start going to advanced interventions, think about all the advanced procedures, whether or not they are needed, and if they're needed, execute. IV therapy. So IV lines are inserted to provide route for immediate replacement of fluid, route for potential replacement in patients at risk of losing substantial volumes of fluid or blood, and route for the administration of medication. So when a decision is made to establish an IV or IO access, it's going to be to keep the vein from collapsing, or KVO. It's going to be for fluid resuscitation, or it's going to be as a route to administer medication. Most protocols will advise the administration of IV fluid in boluses of 20 to 30 mils per kilogram in 250 to 500 mil increments. So we're not going to overload the patient with fluid. So if we get a figure of 1,500 mils for the patient, we're not going to run the 1,500 mils without control. You're going to give it incrementally, and incrementally it can be 250 or 500 mils. And what it means is after every incremental administration, you're going to reevaluate the patient's mental status. You're going to listen to their lung sounds, especially geriatric patient. You're going to monitor the heart rhythm, right? You're going to look at the blood pressure. So you're going to reevaluate the patient after each incremental administration, because we don't want to cause fluid overload, and we don't want to change the viscosity of the blood. If you overload the patient with fluid and it's not controlled, you can change the viscosity of the blood and dilute clotting factors. And there are some patients that we don't want them to get a normal blood pressure. We actually want to keep the systolic within the 90 to 100 range, specifically patients with internal bleeding. So it's very incremental and it's very specific based on the type of patient. We will go deeper into that as the course progresses. Special consideration in fluid resuscitation. Administer only enough fluid to maintain radial pulse if increasing blood pressure is detrimental. Use a Breslow tape or other reference to remember normal vital signs, specifically for your pediatric population. Carefully monitor patient status and treat conservatively in instances of uncontrolled hemorrhage. Only way to maintain fetal perfusion is to aggressively treat the mother. Treatment or treating hypovolemic shock. So we're going to look at assessment and management for the specific types of shock. Treating hypovolemic shock, control all obvious external bleeding. En route to the ED, establish at least one 18 gauge or larger peripheral IV line. So go with the size that, the largest size that can fit that patient. You might want to try 18, but it just can't fit. But the largest that can fit, you're gonna go with it. Secure and maintain an airway and provide respiratory support. Do not give the patient anything by mouth. Monitor the patient's mental status, pulse rate, blood pressure. Provide rapid transport. Treating cardiogenic shock. Ensure systolic blood pressure is greater than 90 millimeters of mercury before administering nitroglycerin. Very important point. So if you are thinking about giving the patient nitroglycerin, you need to bring that pressure up, and you need to do a 12-lead ECG on the patient. Place patient in the position of comfort and administer high-flow oxygen. Provide prompt transport. Gain IV access and administer fluid at a TKO rate. Sure you pay close attention to the specific management for each type of shock. Not everybody you're going to overload with fluid. Not every patient will require an overload of fluid. So you have to be, this is where pathophysiology becomes important. So if you understand the pathophysiology behind what is happening, then you'll know exactly if you need to give a patient a lot of fluids, or you just need to keep the vein open to prevent it from collapsing, or you just need to establish an access to give a medication. Treating obstructive shock, cardiac tamponade. Increasing cardiac output should be the priority. Apply high flow oxygen. Tension pneumothorax. Apply high flow oxygen via non-rebreathing mask. Provide decompression of the injured side of the chest, which I will teach you how to do needle decompression. So I will teach that to you in our skill sessions. Gain IV access as a medication route and administer fluid at TKO rate. Now, if the patient is showing signs of, well, let me not go there. That is for persons above your level. I'm gonna keep it simple. All right, pulmonary embolus. Assess blood pressure, provide a fluid bolus of 250 mils of crystalloid solution. So pay close, I want you to pay close attention. So let me just backtrack a bit, right? So yeah, so note that the shocks that affect the heart directly or indirectly, there is not a lot of fluid resuscitation taking place. So for the shocks that affect the heart indirectly or directly, when we establish IV access, the goal is not to overload the patient with fluid. Ensure that you pay close attention to that. All right. Treating septic shock. Use appropriate standard precautions and transport as promptly as possible. Use high flow oxygen during transport, gain IV access en route, and administer fluid boluses. So patients in distributive shock will need a lot of fluid. They may require a lot of fluid. You're looking at up to 2 liters of fluid in these patients. They may also require what we call vasopressors, which would be outside the scope of your training. It's more paramedics gonna give that. But patients with distributive shock, with the exception of psychogenic shock, the patient might require a lot of fluid. Now, if the patient requires a lot of fluid, remember we're not giving it one time, we're giving it in increments of either 250 or 500 mils. Treating neurogenic shock, best treated by a combination of all known supportive measures. Emergency treatment must be directed at obtaining and maintaining a proper airway, providing spinal immobilization, assisting inadequate breathing as needed, conserving body heat, providing the most effective circulation possible. Treating anaphylactic shock, administer epinephrine by subcutaneous or intramuscular injection. We no longer give epi sub-Q route. IM is the gold standard, and the EpiPen is rarely carried on ambulance units anymore, so you're required to draw the epi and administer the epi to the patient. Promptly transport while providing all possible support, gain IV access. And if you're thinking about IV access, once you're thinking about any advanced procedure, think about all of them. Does the patient need an advanced airway? Yes or no? Does the patient need to be on a monitor? Yes or no? Do I need a 12-lead ECG for this patient? Do I need IV access? Can I get an IV access? No. Can I get an IO? So think about all the advanced procedures. Don't just think about one. And treating psychogenic shock, record initial observations of vital signs and level of consciousness. Try to get information from bystanders. Treating respiratory insufficiency, immediately seal any hole in the chest, stabilize impaled objects in the chest, secure and maintain the airway, and administer supplemental oxygen, and determine the need to assist ventilation. And your need to assist ventilation is going to be based on the category that you place the patient in. Categories 1 to 3, you're thinking about supplemental, high or low flow, unless the patient starts to show signs of severe respiratory distress. Visible chest rise defines respiratory distress. Poor chest rise or no chest rise defines respiratory failure and arrest. And that would bring us to the end of this chapter.